Greetings and welcome, everyone. Thank you so much for joining us on our last session of our final week of the HIV Prevention and Education Virtual Summit. My name is Kyle Shavasta. I am the Public Programs Manager here at the Community Health Training Alliance, an education and training program of Philadelphia Fight Community Health Centers. All month long, we've learned about the issues impacting people living with HIV, as well as intersecting issues. Thank you for being with us the whole month, and thank you for joining us today on our last session. Today, we are bringing a pertinent topic to you as well. But before I hand it over to our speakers, I just want to go over a few brief house rules. The chat is currently disabled, but if you have a question, just put it in the Q&A box. We're going to be monitoring them throughout the session and answering all questions at the end. The webinar is being recorded and it will be uploaded on our YouTube channel, so you can view it at a later time. There will be a survey at the end of the presentation. Please take it and just let us know how we're doing. So with that said, I am so pleased to have with us today Lupe Diaz and Dana Lehman from AIDS Care Group. And today they will be presenting on Brown, Black, and Looking for a Therapist. Thank you so much for being here with us today. And Lupe, the floor is now yours.
Thank you. Thank you for having us. So Dr. Lehman, why don't you introduce yourself and then I'll introduce myself.
Sure. Hi, everybody. My name is Dr. Dana Lehman. I go by Dana. I am the Director of Mental Health and Educational Programming at AIDS Care Group, which is basically a fancy way of saying I am in charge of our internship program, our residency program, our continuing education. I run around and do a bunch of things. I am a health psychologist by training. I've been practicing for about 10 years, and I specialize in working with addiction and chronic health conditions. Also, I have a sort of personal and professional interest in working with the queer community and with people of minority status. So I was really excited when Lupe came up with the idea that we should do this presentation today. It really feels very pertinent given the times we're living in and some of the issues that as a society we're all dealing with. So that's me.
So I'm Lupe Diaz. I also work with AIDS Care Group. I am the Food Insecurity and Wellness Program Director. And you may ask yourself, what does that have to do with what the topic at hand? So I am a huge mental health advocate. It started with when I realized that I needed to be in the mental health system and realizing a lot of the obstacles that there were, especially because I'm a woman of color. And so that started my interest, you know, like what made things tick, how did it happen, how do I find a therapist, all of this. And then as I began being more vocal about my depression and anxiety and, you know, looking for a therapist, my issues that I've had, more and more of my friends started talking to me about their issues. I would start getting calls like, hey, I'm looking for a therapist. How did you do it? So when this came up this year, I was like, I think this is a very important topic that needs to be discussed. So that's a little bit about me. So I'm gonna, wait, am I already sharing the screen?
You are not sharing them yet. So Lupe is gonna share her slides.
Yeah, sorry.
Technology is challenging.
I know.
There we go.
Kyle said to go slowly, and I can see why now. Oh, we started, there we are.
Yes.
So, you know the topic at hand. We told you a little bit about us. My pronouns are she, her.
Mine are as well.
The other thing that I want to discuss a little bit before we start is how I address myself when I speak about my race and ethnicity. You might see me, like you might hear me change the way that I address about myself. So sometimes I will address myself as being Latino because that is the race when I speak in English. Usually everything is the male pronoun when you're speaking in English. So I will say as a Latino. When I'm speaking of myself as a person, not my race or ethnicity, I will say Latina, since I do use she, her. And then sometimes you'll hear me say Hispanic. And that's more like because it's interchangeable for me and for no other reason. But I kind of wanted to explain that because I do realize that I like use them a lot. I will also probably use the term Latinx if I am speaking of the trans community. Okay, so Dana, do you want to do the first slide?
Sure, let's do this. Okay, so just to sort of set a basic framework for what it is we're talking about, we have sort of a main talking point, which is racial, ethnic, gender, and sexual minorities often suffer from poor mental health outcomes due to multiple factors, including inaccessibility of high quality mental health care services, cultural stigma surrounding mental health care, discrimination, and overall lack of awareness about mental health. So that says a lot of things. So I just want to take a second to break that down. A sort of more succinct way of saying this is that when you are not of the majority status, whether that is because of your gender identity, your racial background, your religious background, really any diversity consideration, you are going to have complications and barriers that you need to overcome, right? That's kind of just the way it works. And what we know and what all the research shows us is that we're talking specifically about racial minority in this presentation, although I mean, we know it's true for people of different minority statuses as well. Things particularly related to stigma, to poverty, to lack of access really get in the way for people. And what happens is people do not have access to the services that they need. And so mental health conditions get worse, they don't get treated. The reality is that we have very, very good treatment for many mental health conditions if people have access to them. And if they don't, things do not just disappear on their own. So very often what happens for people, particularly people of racial minorities, is that they do not get the care that they need. Things get worse. It can be intergenerational. Mental health issues can lead to things like an inability to maintain a job, an inability to maintain relationships, and all of these issues that create this self-perpetuating cycle that is very, very hard for people to get out of, which becomes very, very complicated.
Thank you, Jana. So let me read this part. It says racial disparities or unfair differences within the system of mental health are well documented. So there's lots of research on this. Research indicates that compared with people who are white, Black, and Indigenous people of color or BIPOC are less likely to have access to healthcare, whether that be, there isn't healthcare in their area, they might not be insured, the insurance that they can have, doesn't cover all of mental health, so it could be for various reasons. They're less likely to seek out services. So for me, when I started going to therapy, I knew way beforehand that I probably needed help, and I didn't because there was so much stigma in the Latino community about mental health. So I'm like, I can live with this. It's okay, because there was so much stigma, and I know that there are other communities of color where that stigma is also there. They're less likely to receive needed care for whatever reason that might be. More likely to receive poor quality of care. More likely to end services, and this also could be services prematurely. For various reasons. I knew somebody that had 6 sessions and said, I'm cured. And when I was discussing with them, what made them feel that they were cured after 6 sessions, and I kind of was feeling like a failure myself because I was in year 2 of therapy at that point, I realized that there were a lot of issues while in therapy. She was a person of color, and her therapist was Caucasian, and there were a lot of issues that she felt she was being understood. So she just ended it prematurely because of that. And I know that many other people of color feel the same way and therapy prematurely.
You know, Lupe, before we move forward, there was just one thing you said that I wanted to piggyback on. This idea of people in communities of color being more likely to receive poor quality of care. You know, I think one thing that happens that gets really misconstrued when we think about this topic is that we forget that all of these things are interconnected, right? It's not that race is here and poverty is here and racism is here and cultural issues are here. They're all interconnected, right? So if you come from a community of color, you are more likely to have public insurance or no insurance. You are more likely to live in an area where you don't have good access to therapy. And you are therefore more likely to end up in treatment at a place like a community mental health center. Now, community mental health centers are great, right? They provide an incredibly needed service. They tend to have a lot of mental health services. That is fantastic. However, they also happen to be places with very high turnover rates for therapists, with a lot of trainees who come and go. And it can be very difficult to establish a good therapeutic relationship when you know that in 6 months your student trainee is going to be leaving. And that kind of turnover and having to start with a new therapist over and over can lead people to end services prematurely. Trainees have less experience, right? We don't begrudge them that. They need to train, they need to learn. But very often, you know, the way it works is you get assigned a person because they come in and they need
very triggering where, like, you know, like working in the mental health field, you know, at front desk for a little bit, like I know it could be very triggering for patients that might have abandonment issues who
Sure.
have, you know, students, and that makes them stop coming to therapy also.
Right, sure. I mean, who wants to start getting into really difficult, complicated, painful things when they know the person's going to be gone in 6 months and they're going to have to do it all over again? That can be very challenging. Whereas if you have private insurance, or if you are able to pay for therapy out of pocket privately, which is incredibly expensive and difficult to do, you are much more likely to end up in a private practice situation with a therapist who is established and plans on being there forever. So I wanted to highlight that point because it's not necessarily so much about what color the person is, although that is, we're going to get into the racism piece as well, but it also is all related to what kind of access people have and this sort of interconnected piece that I think we have to really, really keep in mind as we move forward.
So now that we're talking about this a little bit more extensively, also, like, the access to mental health care. So I've had private insurance. I've, you know, had same job most of my adult life. So I have private insurance. My first therapist, it was an hour and a half to see her. It was, you know, the therapist that my insurance would cover. I was living in West Philly. I had to go all the way to the main line. And, you know, there were many times where I'm like, I would call her to cancel because I was like, I don't have the energy, because, you know, I was in the middle of a depression, to like travel an hour and a half to get to her. So
you got to get on a bus, you got to schlep all the way out there. You're already feeling
lousy. I was like living in, you know, West Philly, so like I didn't have a car at the point, but yeah, so I had to get public transportation. I had to get the regional rail into the main line, then I had to walk a little bit. And like some days I was like, I don't have the energy for this. So like, you know, like I don't know how like I stayed in therapy the first few years because of that. So like even that, like even if you have private insurance, it can be hard.
Hey, Lupe, I just noticed that there was a question that popped up in the chat. I'm just going to read it out loud here. It says, less high quality mental health care for people of color might also have to do with white therapists being ill-equipped to discuss personal issues or race. For example, I struggle with talking to white therapists about my family because of the amount of judgment and pressure they've already experienced from white community, and many therapists don't understand or address this. I just want to say, we got a whole section where we're going to talk about this. I think this is a very, very important point. So I'm going to leave this question or this comment right here, because yeah, I think this is an excellent point, and we have a lot to say about that.
Yeah, we're going to get to that.
We're right there with you. Yep.
Okay, let me move on to the next slide. So I know it feels like we're jumping, but we're going to talk about suicide rates and why it's higher among minorities, and we're going to give you some numbers and we'll discuss some of that. I have to keep moving. In order to look like I'm giving you eye contact, I have to move the screen to look at everybody. but I have to keep moving it to read the slides. So do you want me to cover this one?
Yeah, you hit this. I'll talk about the chart.
So according to the CDC's Youth Risk Behavior Surveillance, in Philadelphia, 1 in 5 Latina girls have seriously considered suicide, so 20%. 1 in 7 have attempted suicide. So the number's a little higher, but still, that's kind of high. Latina teens have attempted suicide at a larger rate than their counterparts for the last 30 years. So for the last 30 years, like, this is something that hasn't gone away. So let's go to the next slide so you can. Okay, so it's especially important to talk about the mental health stigma that affects Latino women when currently, and by currently, this is from 2 years ago. So that was, I'm doing the math right, 2019, right before the pandemic hit. Currently, so I'm also guessing that this might be higher because of issues with the pandemic. 46.8% of all US Latina high school girls felt persistently, I can read, sad or hopeless to the point of being unable to engage in usual life activities, according to a 2017 report by the US Department of Health and Human Services. The number in Philly shows a sadder story with 50.9%, so just a little higher. A bit more than half of Latina girls have felt persistently sad or hopeless, with 22% considering, so a little less than a quarter, suicide, and 14.6% attempting suicide. So the numbers go down a little, but still high for Latina girls.
Yeah, I think the next slide, we have a graph that I think really puts this into context, because these numbers, as we say, are extremely high. But Lupe, could you?
Yeah.
Thank you. There you go. Sorry, thank you. I got all excited about, well, excited is the wrong word. I got all activated by this because basically we're looking at a graph that shows if you are not white, you are more, generally speaking, not entirely, but generally speaking, you're more likely to think about suicide, to make a plan, to attempt, and to attempt in a more lethal way that requires some kind of hospitalization or treatment, right? I would argue anybody attempting suicide needs treatment, but for the purposes of this slide, what they're talking about is largely medical treatment. What is so striking to me about this slide is basically what we're saying is, listen, the rates are too high, whether you're white, Asian, Black, brown, they're too high. That's a topic for maybe next year. But what's so striking to me about this slide is that what we're saying is that the people who are most at risk for serious depression and suicide attempts, right? People of color who are most at risk are also the people who are most likely to struggle to get the help they need to deal with these factors, right? So you're at high risk for a myriad of reasons. And, you know, if you have persistent depression, if you're thinking about suicide, you need to see a therapist. You probably need medication. You need mental health treatment, right? No one is supposed to have to function in the world feeling like they want to end their life. That's awful. And you're also the people who are most likely to struggle to find that and access those resources. I mean, it does not get much clearer than this graph, which.
So just in case, you know, the graph might be smaller on people's computer screen. The yellow line is the white peers, and then the other graphs are I'm going to call this a charcoal gray, is African American community. The hot pink is Hispanic. This blue is Asian, which we're seeing is a little higher. And then again, it goes a little higher for Native Hawaiian and Pacific Islanders. And I skipped green, which is the Alaskan Indigenous, Alaskan Natives. And we see that the overall US, while our Caucasian counterparts are just at the same line as the overall US numbers, all the other, minus maybe African Americans, it seems, are a little higher.
Hey, Lupe, I want to jump in. We just had a question. Someone said that they noticed that the Native Hawaiian Pacific Islander youth numbers who attempt suicide are very low. Is there an explanation for this?
That is a good question, and I actually asked this myself, and I was trying to find the information, and I couldn't find anything. I'm wondering a little bit if maybe it's underreported, or I don't know a lot about Alaska, so like that's the only thing that I can think of, or I don't know.
So,
half the year.
yeah,
I
I mean, so
I'm a little happier with that vitamin D during that half of the year.
I like the idea that they're a little happier. I have a feeling though that that's probably not it. I think.
But
Lupe
also
is
worrying
exactly
because
right.
the other half of the year they're not getting that vitamin. So.
I don't know that much about Native Hawaiian culture. I will say I know that within Pacific Islander community, mental health issues are generally a thing that we don't talk that much about. And so my best guess is that suicide attempts, if they actually occur, are severely underreported. There is a lot of stigma and shame in that community about mental health issues. So that would be my best guess, but I have not actually seen the research to look at that. It's a good question though.
Yeah, and like I highly suspect that these numbers for all the races are probably underreported because of stigma.
I would agree with that as well. Yeah.
Should we move on to the next slide?
Let's do it.
Okay. Insurance. Who has it? Who doesn't have it? What they have. And I was actually, Dana and I were kind of going through the slides last night, and I was very impressed because she, top of her head, knew like.
I don't know if that's impressive or sad, but yeah, I got a lot to say about insurance.
What? Oh, there we are. There we are.
Okay, so I would love to give just like a quick crash course on insurance, because I got to say, I have been a psychologist for 11 years. I spend a lot of time dealing with this, and it is so complicated. It like makes my head spin regularly, and it's a daily part of my life. And what I have also found is there's a lot of misunderstanding about it. So let's just do like a quick crash course on insurance so we can break down what this means. So people get insurance in different ways, right? Many people, if you have a job that is a legal W-2 above board, not paid in cash job, many employers offer insurance. Either they give it to you as part of your job, or they get a special group rate because they're a large company and the insurance companies want to get a lot of people involved, and you pay a little bit of money out of your paycheck and you have private insurance. Now, private insurance is generally speaking the most widely accepted and what we'd call the best probably. That being said, mental health coverage for insurance is terrible. It's just terrible across the board, right? Whether it's private, whether it's Medicaid. The reason it's terrible is very complicated, but it basically is because we don't think of mental health in this country as something that like really counts as something an insurance should pay for. We think of it as, you know, depression is bad, so like maybe we'll cover a couple of sessions with a therapist, get it together. We don't want to have to pay for treatment that's going to involve a year or 2 years of weekly therapy. We don't do a lot of preventative services in this country. What we do medically and with mental health is we wait for things to get bad and then we try to fix them, which is terrible and does a disservice to people and ultimately does not save insurance companies any money. But that is a fight that I pick with them on a regular basis. All of that being said, oh my God, all of that being said, private insurance is generally the most accepted and the easiest. If you are unemployed or you make below a certain amount of money, you will very often qualify for Medicaid. Medicaid is for people who do not have a lot of money. Now, the benefit to being on Medicaid is you can get things like your prescription medications very inexpensive. Copays tend to be like $1 to $5, which is great because people on Medicaid tend to not have a lot of money to pay for their copays. So that's wonderful. As far as mental health coverage goes, it is not wonderful. Lupe and I work at an organization that takes Medicaid, which is amazing. And I think we do great work here. Most private therapists do not take Medicaid. I, in addition to my work at ACG, have a private practice. I know a lot of people in this field. I don't know a single private therapist who takes Medicaid. And the reason is Medicaid does not reimburse very highly for a therapy session. So whereas a private insurance would probably, people with doctorates tend to get reimbursed maybe $100 to $150 for a private therapy session. The really good ones. There are not many.
Lower. I would say lower from experience, but go ahead.
So actually the one that pays the best is Medicare. That's a whole other thing.
Okay.
But Medicaid pays like 40 or 50 bucks, which is real money. But for people in private practice who maybe have student loans or maybe have certain financial obligations, if you can take insurance that will pay you $150, or you can take insurance that pays you $50, most people go with the 150, right? So that's a problem. Which means that people who already are struggling with access to resources are not able to utilize services of private therapists. And again, community mental health is great. However, turnover is high, and there is so much more of a demand than there is for supply, right? We have 6 or 7 really great community mental health centers in the Philadelphia area. JFK is one in Center City. I was on the phone with them the other day. Their waiting list for a therapist is 6 months. If you are acutely depressed, waiting 6 months to see a therapist is not great. And then if you're uninsured, of course, which is the other block we have here, I mean, if you're uninsured, then, you know, you can get insurance through the marketplace. Some people choose not to do that, but if you're uninsured, you have no mental health coverage, which means that you have to pay privately for a therapist. And a private session with a therapist in Philadelphia these days, I mean, at the low end, will run you $120 a session. At the last data that came out about 2 months ago showed that the average therapist is charging $185 a session. And if you think about going to therapy weekly, most people just do not have $750 a month to spend on therapy. I mean, that's just a financial reality for most people, no matter what their situation.
I'm actually going to self-disclose something. You already know this information, Dana, but I'll self-disclose so people kind of get an idea. And it looks like 3 more questions popped up while we were talking.
Yep, I am looking at them right now.
So I started seeing my current therapist. He was taking my insurance. I'm not going to mention the insurance. I'm just going to say that Penn also has it. And they, you know, were lowballing him. So he decided to stop taking that insurance. I had to decide if I want to start from scratch or if I want to continue with him. I decided to, you know, move my finances around because I have that privilege that I can do that. Moves, you know, some, you know, stuff. Do I really need, you know, to drink, you know, water, you know, the Deer Park versus tap, you know, so I moved some things around, and at this point I was actually seeing him twice a week. So it was
that's a serious financial commitment you made there, Lupe.
I was paying more for therapy than I was for rent. And I live in a house. I rent a house. So like, I'm not going to say prices, but it was a huge commitment. And like, I was, you know, I knew that I could make this commitment because I was coming from a very privileged place to deal with the trauma that I needed to deal with. I also knew that, like, you know, several of our patients, you know, most of our patients and several of my friends also didn't have that type of privilege. And that's when it becomes hard, because oftentimes insurance don't want to pay the amount that a therapist deserves to get paid.
Sure. I mean, and Lupe, it's wonderful that you were able to do that and that you were able to make that commitment. And also it's ridiculous that you had to do that, right? Both of those things I think are true in this situation. That for you to get the good treatment that you needed to deal with the things that you were proactively taking care of, you had to spend more money in therapy than you did in your rent, right? This is why we're supposed to have insurance that's accessible to people. So yes, great that you could. Also, it makes me very angry that you had to do that.
Thank you. So I will have, we will talk about how to find a therapist a Black therapist or a therapist of your race. I'm just answering some of the questions here later on. And I do have a link for Psychology Today where the link specifically helps you find therapist of color.
Yeah, what I will say about these questions, do we have a list of community mental health centers? Yes, we do. Yes, we can share our list about how.
Yeah, you can email Dana later. And
yeah, you'll have my email address. I think there may also be a way, Kyle is moderating this, so I think he can't jump on right now, but that they may be able to send everyone who's attending a follow-up email with that information. But yeah, we can absolutely make sure that you have that. There's also a comment here. I've thought about this issue. If lawyers have some pro bono work, then private practice therapists should be required to have a certain percentage of Medicaid clients. What are your thoughts about that? So personally speaking, in my private practice, I always have two pro bono clients. That's just sort of how I have decided to do it. Now, when I say pro bono, I don't mean free. They both pay me $10 a session. And the reason I charge something is because I feel like it's important to make that kind of financial commitment to say, hey, listen, I am willing to prioritize some money, some personal accountability. People are also less likely to no-show when they have to pay a little something, which is ultimately beneficial for them. The private practice clients that I see pro bono are actually, I used to work at the Attic, which is a queer health center for youth in Center City, Philly. These are actually clients I've been seeing since I worked there. I left about 6 years ago. We've been doing long-term therapy forever. I think, what do I think? I think everyone should do some pro bono work. I think sort of as a human being, it is important to give back in whatever way you're able to do. I think it would be very hard to legally require that. I know some law firms do, as you say, and there are some group practices that do. I don't think you will be able to legally require sole practitioners to do that kind of thing, although I am very much in agreement with you that we all should be contributing in whatever way we can. And, I have the ability to do this, right? Because this is what I've done with my professional career. People do what they can. I'm just looking at some other. Would there be a connection with mental health and substance abuse in regard to the surge of suicide rate, the pandemic, and the social isolation that has influenced? Yeah. So what we have seen, there's a question here about mental health, substance abuse, suicide rates, the pandemic. The really brief answer to this, there was actually just a Times article 3 or 4 days ago. I will send everybody a link about this. Generally speaking, I think to no one's surprise, the pandemic has not been good for anybody's mental health, right? Forget if you had pre-existing mental health conditions, forget if you had substance abuse, forget all of that. The isolation, the fear, the anxiety that has come with the pandemic hasn't done good things for anybody, right? With substance abuse specifically, we have seen a huge, terrifying increase in overdoses and deaths by overdose in the Philadelphia area. In the clinic where Lupe and I work, I think we've had 8 patient deaths since the pandemic started, which is more death by overdose than I have seen in the entire time that I've worked here. From what we can tell, and it's a little bit challenging sometimes, most of them have been accidental overdoses, and a few have been what appear to be non-accidental. The isolation, particularly for people who are trying to get clean, who are in early sobriety. And remember, the patients we see here are generally lower income patients. They may not have internet access in their home, right? They may not be able to go to an online support meeting. They may not be able to, they often have their phones off. So the very few things that are available for people during a pandemic to create that connection, many of them did not have access to. So there's no question about that.
So someone named William said something about the copays, and he said something about 80. So the other thing is therapists are seen as a specialty. So, you know, when I go see like my heart doctor, that's a specialist, so your copay is a little higher. Since therapists are considered specialists, your copay will always be higher versus, you know, seeing like your primary doctor. So that can become very prohibitive. Do we want to move on to the next slide?
Yeah, I'm loving all these questions. We are gonna, yeah, let's move on to the next slide, but we're gonna get to all of them. And we have I think we've set some time aside for question and answers.
Yeah.
By the way, in case you haven't noticed out there, Lupe and I are loving to chat. So I really appreciate everyone sort of jumping in and asking questions and doing all of this. It makes it far more fun than if you just sit and listen to us talk for an hour and a half. So please keep asking away.
So you can cover this, but I'm going to say why I thought this was important. So since we're talking about minorities, there is a huge amount of minorities that are not born and raised here, that they're immigrants. So who also, you know, have feelings and can feel depression. So I felt that it was important to show the insurance rates that people that were either citizens or, you know, natural citizens or non-citizens got. So we can talk about that, because I don't know how to cover this without being political. We know that for a lot of us, especially immigrants and persons of color, the last 4 years prior, that's all I want to say, I'm winking over here, has been hard for a lot of us. I know that in my my therapy, I talked about that a lot. So I felt that it was important to show the coverage that people, you know, that might have not been citizens, that are, you know, minorities had, and how that can affect them being able to get therapy. Dana, I don't know if you want to like talk about anything in this slide.
I think we I think we're going to circle back to this. Yeah, let's. Oh, oops, sorry.
I have to move the screen again. So this one is poverty rate broken down by race, by age and race. Just so we understand where we're coming from when we're talking about, you know, minorities maybe having a more difficult time getting insurance or seeing a therapist.
I think also, not to belabor this point to death, but I'm going to just for a minute. Again, when we talk about living in poverty, right, it's not simply that you might not have good insurance, right, or any insurance. And it's not simply that you may not have a computer at home where you can go to Psychology Today, if you even know what Psychology Today is, and look up an insurance, a therapist that takes your insurance. If you live in poverty, you're very likely to live in an area where there probably are not a lot of psychologists. You know, Center City, Philadelphia, there are like 4 buildings that house 95% of the psychologists in the city. We're all in the same 4 buildings, right? If you're living in poverty, you're not living in Center City, Philadelphia. And if you're living, let's say, way up in North Philly, are you going to be able to get on the train, to come down, to find your therapist, to do that, to go back up? What are you going to do do you need someone to watch your kids? Do you have tokens, right? Many community mental health centers will give people tokens. Private psychologists don't necessarily. Are you going to be able to get there? What are you going to do about having support for food and for other social services? You know, it's not simply the insurance. There are all of these other issues that come with living, you know, in poverty that make maybe you just don't have 3 hours to do that. And you can't do a Zoom session because you don't have internet in your house. You know, there are these other factors which need to be sort of considered when we look at that.
When I started going to therapy, there were some days that I had to cancel because, you know, a bill came up, and I'm like, well, I was like, I can go to therapy and fix the issues that I'm having. And then, you know, I might not have electric, or I can pay the electric, and my mental health will be, you know, where it is right now instead of worse. And then I'll just meet up. Like, so sometimes, like, you know, like you have to kind of balance, like, sure, what is more important. And, you know, being able to live is more important sometimes. Not saying that, you know, mental health isn't important, but like, you know, like we have to prioritize sometimes.
If money were not an issue, we'd all make a lot of different choices in our life, but that is just not the way it goes.
Okay, let's move on to so we're getting to the fun stuff now. I'm being severely sarcastic. Discrimination, it affects our mental health.
So before we jump into this, I have to give my soapbox comment, which I warned Lupe I was going to do, but I really, in all seriousness, think this is very important. We're going to talk about discrimination. We're going to talk about racism. I want to talk about what racism means for a second, okay? Because at least for me, the word racism, or to say someone is being racist, that is very, very loaded. Like, to me, if someone calls me racist, like, that is just horrifying to me. And I think that there are ways in which many of us have this sort of antiquated idea that racism means you hate people of a different race, or you think they're less smart or less capable or less deserving. And while those certainly are racist thoughts, right, that's not really what we're talking about, right? What we're talking about is we are all products of our culture. We are all products of how we were raised. We are all products of how we've interacted with people and what we've been taught to think. And we're really talking in this next part about sort of more subtle, largely unconscious, often ways in which all of us, right? Everybody does this, right? There's this very funny Avenue Q song that Lupe and I were joking about last night called Everyone's a Little Bit Racist, which is a whole other thing. Go YouTube it if you haven't seen it, but it's true, right? We all have ways in which we have prejudices and biases and blind spots that we may not even be aware of that affect us, right? So when we talk about this, you know, we are not saying, you know, we hate people that look different than us. What we are saying is we need to be aware of these things as humans, as mental health providers, as mental health recipients. I happen to be both of those things. And these things play out, and they play out in the ways providers interact with their clients, clients interact with their providers, who has access. This is just a general piece. So I don't want us to be afraid to talk about this. When I find that when we talk about race and racism, usually what happens is the conversation dies, people stop asking questions, and everyone gets a little bit nervous because people are so concerned that maybe they're going to say the wrong thing or accidentally offend somebody, that nothing happens. And that does not help the conversation, right? And it doesn't help deal with this issue. So what I'm really hoping is, looks like there are 85 of you out there in the abyss. I am really hoping that we can all give each other the benefit of the doubt here, right? And assume that if I misspeak, if Lupe misspeaks, if there's a question that is maybe worded in a way that doesn't feel appropriate to some people, that really we're all trying to discuss and learn and get better, and not that we're trying to wrong people or insult people, because having these uncomfortable conversations is how things gets better. Okay, that's my soapbox for the moment.
Okay.
Sorry, Lupe.
So
Go
now
right.
that you get off your soapbox, I'm gonna give some information.
Yes,
so,
please do.
I may get this wrong. I think it's called the mega study, when you put a bunch of studies together to make a new study. Is that what it's called?
The meta-analysis, when you review all of the, meta.
Okay. A meta study, that meta study. Okay, I was saying mega, but it's meta. Thank you. See,
we got you.
Learning. So these are information that I got from 2 different meta studies. So it's various studies that were, anyways. So in addition to triggering sustained activation of stress responses, discrimination experiences may affect health by decreasing an individual's self-control resources, potentially increasing participation in unhealthy behaviors, or decreasing participation in healthy behaviors. For example, research has shown that individuals whose stigma was made salient, thus highlighting the potential for discrimination, had more impaired self-control than those whose stigma was not made salient. I have a hard time. I say
salient, but you're good either way. Yeah.
Okay. So basically, I always tell people, can you tell me what you just read in your own words? So in my own words, you know, something that is, you know, happens a lot in our society. You know, we know that, you know, living while Black is dangerous, that if you get stopped by the police, you know, that there might be a very high risk of you being killed. So that stressor of driving as an, you know, African-American man makes it more likely for you to have some mental health issues, because you're so stressed, because that you know the discrimination in the world might have something happen to you. So like that's
so you're living in a state of perpetual hypervigilance, right?
Yeah,
like
exactly. So like,
something's going to happen. Something's going to happen.
You're releasing, you know, the hormones that create the stress, which is bad for you. So that's kind of like what I'm understanding from that. So let me do the second one. Research examining these pathways suggests that perceived discrimination is related to health behaviors that have clear links to disease outcomes, such as smoking, alcohol, and substance abuse, as well as non-participation in behaviors that promote good health, such as cancer screening, diabetes management, and condom use. So again, you know, you have stressors in your life. Like I know that if I'm stressed out, something happened that day. I jokingly always tell Dana, like when I'm having a stressful day, like I'm letting my eating disorder take over, because like I'm stuffing my face with something. And you know, I'll get home that day, and you know, I know that I'm supposed to run 20 minutes every day, and you know, I have my little machine in my house, and you know, I'm like, I'm just gonna take a nap today. So it's, you know, instead of doing, you know, behaviors that are good for your health and your mental health, you know, focusing on behaviors that, you know, aren't as healthy, such as smoking. Dana?
Yeah, I think I'm just thinking about what you just said, especially the part related to non-participation in behaviors that promote good health, right? So things like cancer screening and diabetes management and condom use. One of the things that I don't know if any of you happened to see the talk that I did last year with a colleague of mine about sexual health, which was very fun.
I knew you were going to bring this up eventually.
I mean, I loved that talk. But one of the things that we talked about is that there was a lot of discrimination, both in the mental health field and in the medical field, right? A lot of racism, a lot of discrimination. And that if you are a person who feels uncomfortable in whatever reason, for whatever reason, with your mental health provider, with your medical provider, are you going to engage in these pro-health, mental or medical health behaviors that are so good for you? Probably not, right? Like we all have our not great coping skills. Lupe's apparently is to like eat all the things. Some people, you know, drink too much. Some people lie on the couch and binge watch 87 episodes of Ally McBeal from 1990. Some people, I'm certainly not talking about myself. Some people sleep with inappropriate partners. People have all sorts of things, right? And really what this meta-analysis is talking about is the idea that if you're already feeling so hypervigilant and so discriminated against and so weighed down by these things, you're going to lean towards your bad coping skill, right? You're not going to lean towards the, oh, I should take a walk, I should call a friend, I should engage with another human, I should eat some quinoa. Like, no, nobody's feeling terrible and wants to eat quinoa. Everybody feels terrible and wants to eat ice cream, right? I don't want to eat quinoa anyway. So that's to me really what we're getting at here.
Okay. Someone mentioned that naps are also good for mental health. True. Okay. No, I didn't.
Yeah,
I'm sorry.
I think, yeah, I'm keeping an eye on the time, unfortunately. And once again, we never have enough time. So I want to make sure that we, the part that people were asking for about finding a therapist.
We'll get there. And we have 45 minutes. So, okay.
Yeah, they had asked that we end a little early so we could do discussion. That's just what I'm keeping an eye on.
Okay, so we have, let's say we have 30 minutes. It's the 2015 meta-analysis. See, I have the word in there. I just forget words sometimes. Trusted source found that racism is twice as likely to affect mental health than physical health. Of those researchers sampled BIPOC who reported experiences of racism also experienced the following mental health issues. So if you experience, some form of racism, you're more likely to, have depression, feel some stress, have some emotional distress, have anxiety, feel some PTSD, and have suicidal thoughts. So like, again, like Dana was talking earlier, how like these things aren't like separate, that they kind of all are, meshed together. Let's move on to the next slide. This one's very colorful. So this is, white adults are often less likely to rate common stressors as significant stress, including discrimination. So we can see, and just again, in case you can't see it, the green is the white community, what do we call it? Is that turquoise or aqua? I'm gonna call it turquoise, is Hispanic. Orange is African-American or Black. This royal blue is Asian. And this lime green is Alaskan Indigenous or Native. So we can see that white counterparts are continuously less stressed than other races are, which can, affect our mental health. Dana?
You got it. I have nothing to add to that one.
Okay, we're moving on. Okay, here's the answer to the question that we had earlier on, finding a BIPOC, Black, Indigenous, person of color therapist. The bad news and the good news. Dana, you want to take this one?
Sure, I will take this one. So what we're looking at here, sorry, I'm trying to move the question thing over here.
Yeah, I know. I keep moving things around.
Let's say you have navigated the system, and we're to talk a little bit more about how you go about finding a therapist to begin with, which is to say, it is not that easy. But let's say you have successfully navigated that system and you have called and you're trying to make an appointment, right? What this graph is really showing is how likely are you to be offered an appointment, right? Now, for example, I don't have any empty slots in my private practice right now. I don't have them. But if somebody calls me, it feels to me that the appropriate, professional, generally decent human being thing to do is to call them back and say to them, hey, I'm sorry, I don't have any slots right now. Can you give me a little bit of a sense of what you're looking for? Here are a couple of referrals, right? Part of my ethics code as a psychologist is to both do no harm and to support people in this journey, right? So do I have to call them back? I mean, no, they're not technically my patients. I don't have to. Do I think it's kind of a terrible thing to do, to not call people back when they're clearly in distress and needing mental health? Yeah, and as I said, I know nothing but psychologists, right? I have lots of referrals. Basically, what this graph shows is that if you are white, you're going to get a call back. If you're Black, you are significantly less likely to get a call back. And it also shows a different form of discrimination, which I think is interesting, which is that middle-class people in general are much more likely to get a call back than working class people, right? No matter what their race is, right? So I think that some of this speaks to a little bit of what we were talking about in terms of internalized racism and classism, and also resources, right? Working class people are far more likely to be calling a community mental health center. There is a question that I think sort of ties in nicely right here. Someone asked, touch on possible ways of addressing some of the issues such as high turnover amongst therapists, student therapists that lead to inconsistencies in care. That's a question that fits in really nicely right here, right? And the reason is community mental health centers generally are trying to do as much good as they possibly can do on a budget that does not support all of the things they need to do, right? And so what does that mean? That means that you know, they're not going to have 3 people answering phone calls for appointments. They're going to have 1. And when that one person is out sick, they may not have a covering person. It means that they pay their staff psychologists and therapists far less, right, than if you work at a for-profit or in private practice, right? What is very, very common in my field is to finish graduate school, go to work at a community mental health center, right, for a couple of years to figure it out, and then to move into the private sector because you make a lot more money and, you know, people want to make more money, right? What that means is that the demand for therapists in mental health centers is very high, and that they never have enough therapists, right? So therapists carry caseloads of 35 or 40 patients, right? If there's 40 hours in a standard work week and you carry a caseload of 40 patients, what I was told when I worked briefly in community mental health was, well, you double book your patients and you hope someone doesn't show up. That's not a great model for treatment, right? First of all, people often do show up, and then you're rushing to fit 2 people in 1 time slot, which means you're not giving anybody quality care. Also, banking on the fact that people are not going to do the thing they need to do so you can cram them in so you can keep your numbers up, the whole thing is poorly laid out. And not every place does this. This is just my example, but it leads to incredible burnout, right? Why would somebody want to stay in a job where they have twice as many patients as they can handle and they're underpaid? People don't want to do that, right? So this question of how to deal with these kind of turnover rates, I mean, this is how this problem gets solved is above sort of my pay grade and my understanding of the city of Philadelphia finances. But the answer is that community mental health centers need to have more resources allocated, particularly right now. I mean, in general, but in this moment right now, Philadelphia is in the middle of this massive opioid crisis, right? I don't know how many people out there are from the Philly area and how many are not, but Philadelphia there's an area in Philly called Kensington. Kensington is the center of the United States opiate epidemic, right? We need so much more mental health care for people than we have, and we need funds allocated to that so that these community centers can support the staff they need, pay them decently, not expect them to see 40 patients in a week. And that is how you get consistency and you lead to less turnover. And people get phone calls back, which, as we see on this chart, is not really happening in general, both related to race and related to income level.
Well, also affects, like, if people are going to stick with in therapy, because the one says any appointment, so that could be anytime during the day. And then the second one is talking about preferred appointments, so a specific time. Usually, from what I understood from when I was reading this article, a preferred appointment is, you know, like 4 o'clock to like
4
6
to 8.
So like after to 8, like after work, right? Because you don't want to take time off if you have to pay bills to see your therapist. So if, you know, you have an appointment at like 2 o'clock, and that means that you have to leave early, and then you have to travel, you know, like let's say that hour and a half that I talked about that I had to travel. So that was 3 hours round trip that I had to travel, and I had to take time off as that, you know, and thank goodness I had a very flexible supervisor at that point, and I made up my hours. Some people don't have, so it's harder. So like if you have a 2 o'clock appointment and you have to leave work like at 1 to get there at 2, and then you have to travel, and you know you're getting home like at 3:30, that's a long day, and you're less likely to, like, you know, to want to continue that. So it makes it harder for people who want to stay in therapy if they're lucky enough to get into therapy. Okay, moving on. Tina, because like I'm already feeling myself being triggered all over again. So I'm gonna tell everybody, I did these slides, and when I was doing this slide, I texted Dana and I said, I think I'm done with this presentation because I was I've read this article before, and for some reason I was so triggered that I got so mad by it that I was like, I'm done with the presentation. So Dana, do you mind like just taking it?
I will take this slide. Absolutely. So everyone can read this. I'm not going to read out every line here, but I think the gist of what we're talking about here, and this is, again, this comes back to this discussion of racism and discrimination, is if you are white, you're going to get a call back from a therapist. If you are Black, if you are a Black man, the likelihood of you receiving a phone call back is very, very small. I mean, you see right here, to get an appointment with a therapist, this is what we're talking about. In general, the average Black man is going to have to make 80 phone calls. I don't even know 80 therapists. I'm not sure you can find, I mean, we live in the city of Philadelphia, and I don't know if there are 80 psychologists within the, I mean, there probably are, but like, that's insane, right? Can we think about that? Can you imagine being in the position where you're already anxious about doing this, right? No one's excited to call a therapist, right? You're calling a therapist because something is not going great. You're not calling a therapist to talk about how wonderful your life is, right? So you're already probably a little anxious, probably not having the best day of your life. And you have to work yourself up to call 80 people and probably leave 80 voicemails and then sit around for someone to call back. I mean, no wonder people don't get mental. I wouldn't call 80 people. I would call a couple and I would give up. And that's on a good day. If I was having a bad day, I mean, can you imagine being that depressed or that anxious or struggling with that kind of trauma and then trying to work yourself up to do this 80 times? It's insane, right? So if you're a Black man and perceived to be poor, right, then you're really in trouble. If you're a Black human, the numbers are not much better. If you're a white person, if you have a 28% chance of being called back, that's a slightly better than 1 in 4. So you have to make slightly less than 4 phone calls, or you could be a Black man and have to make 80, right? Now,
So ridiculous.
It's horrifying. And so here I am a white therapist. I like to think of myself as pretty evolved, pretty aware. I would hate to think of myself as a human who would do this. I imagine that most therapists think of themselves as pretty open-minded and aware and would not like to think of themselves as people who would be one of the 80 people that a Black man would have to call in order to find a therapist, right? That's not great. And so when we're talking about internalized and systemic racism, this is what we're talking about, right? We're not talking about people sitting around thinking, well, this man is probably Black and I don't want to work with him. We're thinking about ways in which the way people speak, or if they're perceived to be poor, maybe they had less education, maybe their grammar is less good. Maybe they don't know the buzzwords about therapy, and so we have certain immediate connotations with that. Maybe they, you know, are super anxious and they're sort of haphazard and disjointed on the phone, right? And
That's
maybe that
me
makes
when I call like any appointment, like
sure.
Sure. So that would make, and there is a term for this. And I laughed because I had remembered it. So this article that triggered me so much had a term for this. It's YAVIS, Y-A-V-I-S, and it stands for young, attractive, vocal, intelligent, and successful. And basically what they're saying is that people are more drawn to this type of person. So internal biases that people might not be aware that they have make it more like, oh, I'm going to call this person, and make it harder for them to call somebody else that they might not see under those categories. So again, you know, it's not something like, no one's, you know, like wakes up in the morning and say, you know, like, I'm not going to call anyone of color, like, to make an appointment.
No,
like,
that is of course not what we're talking about.
Yeah. So, okay, we're going to move on because like I'm feeling myself getting angry.
We got lots to say about this. We'll just keep it going.
Okay. Oh, here we go. I'm having, oh, here we go. So food for thought. According to the 2015 study by the American Psychology Association, 83.6% of psychologists are white, while only 14.6% are Black, Latinx, or Asian, and 1.8% are multiracial.
We did realize last night that these numbers do not add up to 100%.
They do now.
Oh, they do now. Oh, we changed them. Excellent. Okay, we did fix that.
I'm like, what did I miss? And I had missed.
Nope. I'm sorry, my mistake.
When you pointed that out, I was like, I missed something, and it's multiracial. I had missed. So I was curious about this. I'm like, so what is America broken down to? So I Googled this morning. 52.6% of America is white. So the numbers are a little skewed here in this.
So I just want to say something about this. So if what we are saying is that 52% of America is white, which means almost 50, yes, this is for psychologists. We just got a question about this. This is only for psychologists, not social workers and LPCs. I'll talk about that in a sec. That is a good point. So yes, a little more than half of America is white, and yet 83% of psychologists are white, right? So what that means is that if you are a person of color looking to work with a psychologist, you are going to have far fewer, a psychologist of your own race, right? If you're African-American, you're looking to work with a psychologist of your own race, you're going to have a far smaller pool to look at. Now, there's a question in the chat about just psychologists, not social workers or LPCs. Now, just a quick rundown for people who don't know. There are different degrees that you can get to work in the mental health field. Psychologist means that you have a doctoral degree in mental health, basically. Social workers are a master's of social work. Social work degrees are slightly different. You can work as a therapist with a social work degree. You also may do things that are more related to community involvement, community outreach, helping with resources, or you might work as a therapist. And LPCs are people that have a master's degree in psychology. So you didn't get a doctorate, you got a master's. These are all really good degrees. They have sort of different areas of focus. I would imagine, Hannah, someone named Hannah put this question up. I don't know if you know the answer to this. I would imagine that there are many more social workers and LPCs who are people of color than psychologists. And the reason that I would imagine that is because it takes 2 to 3 years to get a social work or an LPC degree, and it takes 5 to 8 years to get a doctoral degree in psychology. And many doctoral degrees in psychology are also not funded. And so you need to either be able to pay privately for a 6-figure doctoral education, or you got to be able to take out a lot of loans. You have to be able to take a lot of time off from a profession where you are working and making money. And that requires a certain amount of access and financial privilege. And the reality is that people of color are less likely to have that. So they have many more barriers to overcome if they want to get a doctoral degree, because it's easier to take loans for 2 or 3 years than it is to take for 5 or 8 years. I mean, that's just the reality. And it's easier to take that kind of time off. And if you have that many additional barriers and what you're looking for is a degree that allows you to be a therapist, if it were me, I would do it quicker too. Sometimes I wonder why I got a doctorate. I could do a lot of the things I'm doing now without having done that. So I imagine that the rates are more comparable with the social worker LPC. I would imagine. I would have to look at that. But I think your point is a good one.
I'm reading the comments.
Yes, there is a place I know in Philly that you can volunteer to help people find therapists. I will put all of that information in the follow-up email. Sure do.
Okay, so I'm not even going to read the second part so we can keep moving. I'm sure that people have read it while we've been talking. Sorry if that came out. So know what you're looking for when you're looking for a therapist. And I'm putting some examples that I thought of, that I came up with while I was looking for a therapist the second time. So someone that understands a second language you may speak. I put that in because my first therapist did not speak Spanish, and half of my therapy was me translating what my mother said to me, and sometimes things don't translate, correctly or just the same. So then I would have to say like what the meaning was and like a history. My current therapist speaks Spanish, and he understands a little better. Sometimes I have to slow it down. I had to explain to him like colloquialisms that he doesn't understand because he learned to speak Spanish in a different country from where I am. But it's helpful. It's cut off half that time of me having to explain or translate for him. Identity factors. So if you're in the LGBTQ community, do you want a therapist that's, within that community too? We could put many other things. A similar background as you, so you don't have to explain, why something affects you as much as it has affected you. Not feel the need to educate your therapist on your experience, and someone who affirms your experiences.
I think there's a comment in here. Can you just go back one slide for a sec?
Yes.
There's a comment in here that I think really kind of speaks to exactly what you're talking about. Somebody said, going a couple slides back, although I think also this slide as well, the hypervigilance aspect of this discussion is important. As a Black woman, I feel like this comes up a lot in my own therapy, and it's been a huge help that I have a Black female therapist who can both identify with those feelings and help me navigate them as they come up. Yeah, I mean, I have some clients who are Black. I have some who are not. I think I can work with people of all races. I also do not have the lived experience of being a person of color and feeling hypervigilant about my safety if the police pull me over. I've been pulled over a couple of times. I've never worried about it. I think I can empathize. I would like to think that I have an intellectual understanding of how terrifying that is. I can't relate to that. And I think part of my job as a psychologist is to be aware of that and to think about if I am able to do right by my clients. Some of my clients are not, in therapy for issues related to this kind of stuff, and it's fine. But, I had twin daughters 4 years ago, and when I went on maternity leave, I was working with a client who was a first-generation Indian American woman, and I referred her very specifically to work with a psychologist I knew who was also a first-generation Indian American woman, and she actually gave me a lot of pushback about this and was like, Dana, I think you're like reading into the race thing too much. And I was like, I don't think I am. Like, humor me, and you're going to see someone anyway. She's excellent. I think it would be great for you to have this experience with someone who I both know is excellent and can relate to being an Indian woman and being a first generation woman in the United States and all of these things. And it was a fantastic experience for her. And she came back to me and we continued to do great work together, but she was able to get something out of that work with this woman that I couldn't give her. I'm not a first generation immigrant. I don't have Indian heritage. I just don't,
It's different. I have to explain. I still, even though my therapist speaks Spanish very fluently, sometimes better than I do, there are certain things I still have to stop and explain to him, even though I feel that he has an understanding, and I know that he empathizes. I still have to stop and explain certain things sometimes. So it's hard, and it does help having somebody that you don't have to explain some of those details, that understands, because they've also lived that. And it's hard to find somebody like, going back to the those numbers, when I looked, the reason I read that the Atlantic article was because that's when I was starting to look for a new therapist. I had broken up with my first therapist, and I was looking for a new therapist. And my numbers were, I called 20 people. I got 6 callbacks. I got 3 appointments out of those 6 callbacks. And, you know, out of those 3 people, the appointments that I got to pick one. But still, that's 20 calls. And I was in the middle of a depressive episode. Like, that's hard. And then it's harder, like, you know, because I wanted to find somebody that understood me as a Latino woman better. And I ended up with a white man, but he speaks Spanish. So, like, you know, I had to balance it out. And I think that's hard sometimes. Let's go back. We're almost done. And then we can answer all the questions. Okay. So some key factors to help find a therapist that you might want to think about is, you know, consult your provider directory of your insurance if you have it. Ask someone who you trust who's been to therapy. Like, you know, I always help all of my friends, you know, when they're going through it.
Everyone should just call Lupe if they have questions about this.
Call me. My last search, you know, like I asked my supervisor at the time, I was like, I'm looking for a new therapist. And I didn't even know what to look, because like the first time, like I called my insurance, they gave me a name, I called, and, you know, and it wasn't, you know, I was with her for a long time, but in the long run, it wasn't the greatest fit. I needed somebody. So like he sat down with me. So like, you know, having somebody to help you guide you is helpful. So if you can do that, like give somebody, you know, that help, it's great. Use a reliable online database. I am a firm believer in Psychology Today, who has a very comprehensive list of therapists in your area. Explore local resources. Ask, you know, other, like, you know, I asked my medical provider, I was like, hey, like, you know, your pen, do you have any providers that you can recommend? Reach out to organizations that address your area of concern, and think about your goals ahead of time to know like what kind of therapist you want to see. Sorry, I'm moving things around. So you can also ask them questions like, this isn't the first, I always say that the first appointment is really like, you know, it's your first date, you're interviewing them. You don't have to, you can decide if you don't want to continue seeing them. So, you know, ask them, do they have other clients like you? So like they, you know, if they, you know, they have already some knowledge of who you are as a person, what you've dealt with, what are their experience with people like you? Are there any experiences with your culture? Like, this is how I found out that my therapist spoke Spanish. Like, I asked him, I was like, do you have any experience with Latinos? Have you ever? And he was like, oh, you know, I lived in Costa Rica for 2 years. Like, I'm fluent in Spanish. And I was like, oh, but I wouldn't have known that. I might have known that like 6-7 sessions in later, but that really like helped me realize this might be the therapist that I want, because I don't have to stop to explain that. I can just continue. Their insurance, do they take your insurance? And then they have a sliding scale fee.
Yeah, I just wanted to piggyback on something you were saying there, Lupe. Whenever I have a first session with a client, I always give the same disclaimer, which is, I sort of joke around a little bit and I say, listen, assuming the first session is not a complete disaster, which I imagine it won't be, what I generally like to do is meet with people 2 or 3 times, get a sense of, you know, if this feels like it may be a good fit, and then we'll have a discussion about that, right? And if it's not a good fit, that's an okay thing for you to tell me. I mean, it's important to remember that in that dynamic, there's a power differential, right? And, you know, clients will very often not want to say things, not want to offend you, feel really bad. And you want to make sure as a therapist to give space for like, listen, and I say this exactly. I say, listen, you can be the most brilliant therapist ever, and you still may not be the right match for someone, right? And there's no point. Therapy is incredibly vulnerable. It's incredibly personal. And if you're not comfortable with me for whatever reason, you're not going to get what you need out of this. And it's not going to be a good use of your time. And likewise, if I feel for whatever reason that there's some reason that I'm not a good match for you, personal, professional, whatever it is, I have an obligation to say to you, hey, listen, I just don't think this is the right match, and to give you some referrals. You can say that to me. It's okay. You're not going to offend me. you're doing a really delicate dance at the beginning of therapy. How does this work? How does this feel? Do we think we want to do this together? But especially for people who haven't been in therapy before, they don't know that that's an option. Like, they probably don't know that a sliding scale fee exists. What does that mean? It has to come both ways, because part of my job, especially for someone who hasn't been in therapy, is to educate a little bit about what the therapy process is like. And if you have been in therapy, my job is to educate you about what my therapy process is like, right? I don't know that well how other people do things. I know how I do things. And you're going to maybe like my style and maybe you're not, and that's okay. But I have to give space for people to be able to do that.
Again, self-disclosure. So one of the therapists that I interviewed while I was looking for a therapist this last time, she was an amazing therapist. And there was 2 reasons I knew that she wasn't going to be a good fit for me. Her office was very disorganized and it was very triggering for me. Like, I wanted to get up, like, interviewing her and start organizing her office. And I know it's a huge no-no. I know that's a big thing I can't talk. And I'm like, I'm not gonna be able to do this. The other thing was, she was heavily relying on motivational interviewing, and I caught onto it because, I worked in the mental health field. I read a lot about it. Like, I was like, this is a lot of motivational interviewing going on. And I was like, I would catch her doing it, and I would start thinking about that, and I couldn't think about like what she was asking me. So like, it was just a horrible fit. Like,
great therapist, not a great therapist for you.
I discussed things that I had discussed with my first therapist ever with her in that one session. But those 2 things, I'm like, I'm going to want to be cleaning this office every time I come in here and dusting. And that's a huge boundary that I shouldn't be crossing. So I knew she wasn't going to be a good fit for me, even though she was great. So like, there's so much. And I know that like, like you were speaking of like things that people don't know. I think that, society has taught us that, like, if you have the word doctor, if someone's, treating you somehow, that there's this power dynamic. And I think people don't realize that you can, say no, or you can say, like,
yeah.
My therapist and I, like, and this, I always tell you, I'm like, I had to remind them that, like, I didn't want to discuss this. You're in a place of power. It is your session.
100%.
So, yeah.
Be able to say yes or no. And if you don't feel comfortable doing that, you are with the wrong therapist.
Yeah, exactly. Oops. Sorry. Anyways, let's just move it on. So I put this in. I hope everybody knows who DeMar DeRozan is. If you don't, he's an amazing basketball player. And in 2018, he was really depressed, and he put this tweet out there. This depression gets the best of me. ... He says that he put that out there, put his phone down, went to sleep. He woke up and this had gone viral. He had never talked about his depression, and because of this, like, he is a huge speaker on mental health. After this, after the NBA realized that he was so depressed and he talked about it, the NBA, now each team has a psychologist that each team member has to. So talking about your mental health, especially as a person of color, opens up other people seeing that it is okay to talk about it, that they too might be going through something and doing something about it. If DeMar DeRozan hadn't decided to be brave and put this out there, the NBA wouldn't have made these changes. And there's a lot of other football players. Wrong game. A lot of other basketball players have said that this has made a huge difference for them now, having a therapist that they can talk to, when that wasn't, it wasn't allowed, it wasn't normalized before DeMar DeRozan spoke about it. There's a comment.
Sorry, I'm just checking out the comment inside.
So Dana, I think this question is something that you're more equipped to answer than.
Yeah, so I'm going to read this out loud because I'm reading it as we say. So may have missed this at the beginning since I was slightly late, but what are some signs that therapy in general isn't a great fit for your life? In the Black community, there's still some hesitancy regarding the label that they prefer to seek out spiritual counseling, life coaching, etc. As a Black person, I feel many in the Black community are more accepting of those types of resources as opposed to therapy. Is it all the same type of work? Okay, that is a great question. Stigma in the mental health community, that is so real. It is real in general. It is far more real in communities of color. Like Lupe was just saying with this basketball player, an amazingly brave thing that he did. Even more amazingly brave that he did it as a person of color in such a public place, right? There is still this idea that like, oh, you're in therapy, like something must be really wrong with you. You must be crazy, right? I mean, the term crazy doesn't actually mean anything. I think maybe we're talking about psychotic. I mean, there are psychotic people. 99, I shouldn't quote statistics. The overwhelming majority of people are not psychotic and they're not crazy. And I don't even really know what that means. They are people, and sometimes things are hard. And sometimes it really helps to have a person who is not involved in your life, who only knows you in the context of what you bring into the space, who you don't have to see at a family barbecue, who you can talk about this with, and who, by the way, is legally and ethically required to keep things confidential, right? There is a real power in knowing that what you say is staying there. If I repeat what is said to me, I can lose my license, and I worked really hard to get it, and I am not gossiping for anything. Not happening. But yeah, your comment about how it's easier to accept the idea of spiritual counsel, life coaching, etc. Are these the same type of work? No, they are not. And let's just talk really briefly about the difference.
We have 5 minutes.
Just 5 minutes. Okay, 5 minutes. We're gonna do this real quickly, and then if you want to talk more about this, I am all about it. Lupe,
while you do that, I'm going to put
our contact information up.
And there's our contact information if you guys.
Correct. So the very quick answer is, so life coaching is sort of a newer field. I'm not sure exactly when it started. I remember it becoming kind of trendy in the mid-90s, which dates me a little bit. And it used to be that life coaching, similar to the term therapist, didn't really mean anything, right? By the way, anybody can put the sign on their door and call themselves a therapist. It is not a protected term. You don't need a degree. Like my 4-year-old can do it, doesn't matter, right? There are now life coaching certificates you can get. As far as I know, there are no sort of like official accredited life coaching schools, but you can do certificate programs. Life coaching has more to do with motivation and helping you think through sort of career and life plans. Spiritual counseling tends to have a religious or some kind of spiritual basis. Psychology and mental health, unless you get you can get a mental health degree in Christian counseling. But generally speaking, they're non-denominational degrees. What I am trained to do as a mental health provider that a life coach or a spiritual counselor is not trained to do is, I am trained to diagnose and treat depression. I am trained to diagnose and treat post-traumatic stress disorder, anxiety, all of these things. You cannot be diagnosed with a mental health condition without a person who has a licensed degree in mental health, right? Or working under someone who does. A life coach can't do that. You also cannot get insurance reimbursement for things like life coach and spiritual counseling, and you can't be trained you are not trained to treat mental health disorders when you have a life coaching or a spiritual counseling background. I mean, you may get training in that additionally, but being a life coach in no way qualifies you to treat mental health issues. They can be very motivational, they can be very helpful, a lot of people benefit from them, but I would not recommend going to a life coach or a rabbi or a priest or a minister or an imam or anybody to treat those conditions, to talk about what's going on, talk about your struggles, get support 100%. To treat mental health issues, I would not. And that's probably, I'm probably out of time, so out of time here.
You have 1 minute.
I have 1 minute.
I would say that's a great first step.
Yeah.
And you know, like if you've noticed that like you're still having issues, then maybe taking the second step of seeing someone with a degree in therapy.
And what I will say in my last 30 seconds is that I just feel like the best thing we can do is what Lupe is already doing. I was joking with her like 6 months ago. I was like, you're really a mental health advocate. What Lupe does by talking about this, talking about the fact that she struggled with depression, talking about the fact that she sees a therapist and being very public about it, is that she destigmatizes it, right? Like Lupe is just a person. She's a colleague of mine. She's a friend of mine. She lives her life. She does her thing. And she has struggles and she's managing them, right? And that's, you know, that is the best thing you can do across the board, and particularly in communities of color, because the more you do it, the more other people are like, oh, wait, I struggle with that too, or I'm also in therapy, or, you know, making it part of the conversation and getting rid of the shame. And we did not have a question and answer period because we ran out of time.
I think the question and answers through the whole thing, though.
I think we sort of did. I don't know. Sorry, Kyle.
No, I want to say thank you for providing this thought-provoking presentation. This is, Lupe, what, your 4th presentation around mental health advocacy? And this year you did it around the call to action of health equity and addressing you know, disparities in healthcare. So this has been a tremendous, tremendous presentation. Thank you both for providing work, labor, and lots of food for thought, and a lot for us as professionals to think about. So thank you so much. And I want to thank the audience for being so engaging and asking really wonderful
We loved it. Thank you.
questions. Dr. Lehman and Lupe, you made my job really easy. I didn't have to ask a single question. I didn't have to play talk show host, which
we aim to please.
Which is often awkward for someone on the autism spectrum to have to navigate all these things. So thank you, thank you. And everyone, thank you for being with us this month during AIDS Education Month and the HIV Prevention and Education Summit. Please take the survey at the end. This is the last survey you all have to take. And everyone be well, have a good summer, and we'll see you in future presentations. Take care, everyone.
Thanks, everybody. Be well.